I want you to picture something very familiar. You wake up at 6 in the morning. Your knee aches. Your shoulder is stiff. Maybe you have a low headache from sleeping in the wrong position. You walk to the bathroom, open the medicine cabinet, and there it is. The white bottle, acetaminophen, Tylenol, the thing every doctor, every pharmacist, every television commercial has told you is the safe choice. The gentle one. The one that won't hurt your stomach the way ibuprofen does. The one that is, as they say, doctor recommended. You take it and go about your day. I need to talk to you about what happens next. Not the pain relief, that part works. I want to talk about what is happening inside your liver at the same time. Because after the age of 60, that calculation changes in ways that most people, and honestly many physicians, have never fully explained to their patients. My name is Dr. Marcus Whitfield. I've spent more than 2 decades working in longevity medicine, and the most dangerous health threats I see in patients over 60 are not always the dramatic ones. They are not always the things that announce themselves loudly. They are the quiet ones, the ones hiding inside the ordinary routines, the ones that look exactly like good decisions on the surface. A quick note before we go further. I am an AI avatar. The medical information in this video is drawn from published research, including studies from the NIH, the FDA, the Mayo Clinic, and peer-reviewed journals, and I will give you those sources. But this video is educational, not a substitute for personal medical advice. Your situation is specific to you, and your doctor needs to be part of any decisions you make. Please do not change how you take any medication without speaking with your physician or a pharmacist first. Now, let me show you what I mean. The thing nobody puts on the label. Acetaminophen is the most widely used over-the-counter pain reliever in the United States. More than 25 billion doses are taken every year in this country alone. It is in Tylenol, yes, but it is also in NyQuil, Dayquil, Theraflu, Excedrin, Percocet, Vicodin, Benadryl PM, ZQuil, and hundreds of other products. Most people have no idea how many sources of acetaminophen are coming into their body on a given day. That is the first trap, the combination products trap. And we are going to spend time on it because it is where the majority of accidental liver damage begins. But first, I need to give you the foundational picture. I need you to understand what acetaminophen actually does inside your body and why the equation shifts so significantly after age 60. How your liver processes acetaminophen and why age changes everything. Your liver is the primary site where acetaminophen is broken down. When you take it, the vast majority of it gets converted into safe, water-soluble compounds that your kidneys can excrete. That process works well in most people most of the time. But there is a secondary pathway. A small fraction of every acetaminophen dose gets converted into a highly reactive, toxic compound called NAPQI. N-acetyl P-benzoquinone imine. Under normal circumstances, your liver neutralizes NAPQI almost immediately using a protective molecule called glutathione. Glutathione binds to NAPQI and escorts it safely out of your body. Here's what changes after 60. Your liver shrinks, literally. Liver mass decreases by roughly 20 to 40% between age 30 and age 80, according to data published in the journal Drug Metabolism and Disposition. Blood flow to the liver declines at a similar rate. This matters because liver processing capacity is not just about chemistry, it is about volume and throughput. A smaller liver with reduced blood flow is processing the same amount of acetaminophen more slowly. Your liver enzymes change. The enzyme systems responsible for the primary safe breakdown pathways become less efficient with age. This means a larger relative fraction of each dose gets pushed toward the NAPQI pathway. Your glutathione reserves fall. Glutathione production declines with age. A 2019 study published in Redox Biology documented significant reductions in hepatic glutathione synthesis in adults over 65. Less glutathione means less capacity to neutralize NAPQI before it causes damage. The result is that the same amount of acetaminophen that was metabolically manageable when you were 45 may produce a meaningfully higher toxic load on your liver at 65. Your body's margin for error is narrower. The buffer zone has shrunk. The FDA and the American Geriatric Society have both flagged this. The AGS Beers criteria, the primary clinical reference used by geriatricians to assess medication safety in older adults, includes specific cautions around acetaminophen use in aging patients. Not because it is dangerous in the way that many drugs are dangerous, but because the assumption of complete safety is not supported once you factor in the biology of aging. Here is what concerns me most. Nobody told you this. Your pharmacist probably did not hand you a pamphlet about hepatic glutathione depletion when you bought a bottle of Tylenol. Your primary care physician, who is managing your blood pressure and your cholesterol and your diabetes, may not have specifically discussed this with you in a way that changed your behavior. Because it seems small, because acetaminophen is everywhere and people take it constantly, and most of the time, nothing dramatic happens. But most of the time is not the same as safe. The combination products trap, the thing that is actually hurting people. I want to spend real time on this because in my experience, this is where people get into genuine trouble. You have a cold, you take NyQuil at night to sleep, you wake up stiff and take 2 Tylenol for your joints. By midday, your head aches again, so you take an Excedrin. In the evening, you take your usual Benadryl PM to help you sleep. Now let me show you what you have actually taken. NyQuil Original contains acetaminophen. Tylenol Extra Strength, acetaminophen. Excedrin Migraine, acetaminophen. Benadryl PM contains acetaminophen in some formulations or is sometimes combined with Tylenol PM, which does. On a bad cold day, a person following what seems like completely reasonable over-the-counter medication habits can easily accumulate a total acetaminophen load that far exceeds what their aging liver was designed to handle safely. The FDA's maximum recommended daily amount for healthy adults is already carefully calibrated. For older adults with reduced liver function, that threshold is even more conservative. Many physicians who specialize in geriatric care recommend that patients over 65 check with their doctor about what total daily amount is appropriate for their specific situation. The point is not a number I should give you here. The point is that your total intake from all sources combined is what matters. And most people are not adding it up. A 2005 study published in the Journal of the American Medical Association found that acetaminophen hepatotoxicity was the leading cause of acute liver failure in the United States, surpassing all other causes including viral hepatitis. And in the majority of those cases, the damage was unintentional. People were not trying to take too much. They were doing exactly what the labels told them to do. They just did not know how many of their products contained the same ingredient. This is a system problem. Acetaminophen is listed on medication labels. It is there in the fine print. But the name shifts. You see acetaminophen on one label, APAP on another, and paracetamol on a third. They are all the same molecule, and many people simply do not know to look for all of them. What I want you to do, right now or very soon, is go to your medicine cabinet and read every label. Every cold medicine, every sleep aid, every headache tablet, every prescription pain reliever if you have any. Write down which ones contain acetaminophen or APAP or paracetamol. That list is your total picture. Share it with your pharmacist. That conversation takes about 5 minutes and could matter a great deal. The alcohol interaction, a risk that is far more common than you think. The next hidden risk I want to talk about is alcohol. Many adults over 60 have a glass of wine with dinner, or a beer in the evening, maybe 2 glasses on the weekend. That sounds, and in many contexts is, moderate and reasonable. But when it comes to acetaminophen, even that level of drinking changes the risk picture. Here is the mechanism. Alcohol and acetaminophen share overlapping liver pathways. Specifically, alcohol activates an enzyme called CYP2E1. This enzyme is one of the routes through which acetaminophen is converted to NAPQI, the toxic intermediate I described earlier. When CYP2E1 is activated by regular alcohol consumption, more of each acetaminophen dose gets shunted toward NAPQI production. At the same time, chronic alcohol use depletes glutathione, the very molecule your liver uses to neutralize NAPQI. So you get more poison being produced and less capacity to neutralize it. both simultaneously. A 2012 review published in Pharmacoepidemiology and Drug Safety analyzed this interaction specifically in older adults and found that the combination creates a disproportionate risk increase compared to either factor alone. The risk is not additive. It behaves more like a multiplier. The FDA has required a warning label on acetaminophen products about this for years. If you consume 3 or more alcoholic drinks per day, the label says, ask your doctor whether you can take acetaminophen or other pain relievers. Most people read past that warning. Most people do not consider themselves heavy drinkers and do not think the warning applies to them. Here is what I want you to hear. The cutoff on that label is a regulatory simplification. The actual risk gradient is not a cliff that begins at drink number 3. The research suggests that even regular, moderate alcohol use raises the risk, particularly in combination with the physiological changes of aging I described earlier. And the risk is higher for people who are also taking acetaminophen regularly for a chronic condition. If you drink regularly, even moderately, and you also use acetaminophen regularly, that is a conversation worth having with your doctor. Not a reason to panic, a reason to have a conversation. The warfarin interaction, the one your cardiologist may have overlooked. Now I want to talk about something that is especially important for the large number of adults over 60 who are on blood-thinning medications, specifically warfarin, which is sold under the brand name Coumadin. Warfarin is one of the most common medications prescribed in older adults. It is used to prevent stroke in people with atrial fibrillation, to prevent blood clots after joint replacement surgery, to manage various cardiovascular conditions. It is an extremely effective drug. It is also a drug that requires careful, ongoing monitoring because its effects are influenced by dozens of factors. Acetaminophen is one of those factors. The interaction between acetaminophen and warfarin has been studied extensively. A 1998 study in the Annals of Internal Medicine and several subsequent studies found that regular acetaminophen use can elevate INR in people taking warfarin. INR is the measure of how quickly your blood clots. Elevating it too far increases bleeding risk. A 2015 study in the British Journal of Clinical Pharmacology confirmed and quantified this, finding that even amounts of acetaminophen that are within the general adult recommendations can raise INR significantly in warfarin patients. The mechanism involves acetaminophen's interference with vitamin K-dependent clotting factors at the hepatic enzyme level. Your liver makes the proteins that allow your blood to clot, and acetaminophen can affect the enzymes involved in that process. When you are already taking warfarin to reduce clotting, that additional push can take you outside your therapeutic range. Here is the particularly dangerous part. Many physicians recommend acetaminophen to their patients on warfarin specifically because it seems safer than NSAIDs like ibuprofen, which have their own bleeding risks. That recommendation is not wrong. Acetaminophen is generally preferable to ibuprofen in this population for a different set of reasons. But the recommendation sometimes comes without the instruction to increase INR monitoring when acetaminophen use begins or increases. If you are on warfarin and you take acetaminophen regularly, even occasionally, your INR should be monitored more closely during periods of regular use. Your anticoagulation specialist or the physician managing your warfarin needs to know your acetaminophen habits. If they have not asked, bring it up yourself at your next appointment. This is especially true if your acetaminophen use varies. If you sometimes take none and sometimes take it every day for a week because your arthritis flares, that variability can cause your INR to swing in ways that are difficult to predict. Warning signs your liver is under stress. I want to give you the warning signs, not to alarm you, but because this is information you should have. Early acetaminophen toxicity can be genuinely difficult to recognize because the initial symptoms can be vague and easy to dismiss. Nausea, a sense of not feeling well, loss of appetite, mild abdominal discomfort, particularly in the upper right area of your abdomen where your liver sits, fatigue that feels different from your usual fatigue. The problem is that within the first 24 hours of significant acetaminophen overload, these symptoms can be subtle. then they often temporarily improve. Then, if the damage has been substantial, symptoms return more seriously in the following 24 to 72 hours. By that point, without medical treatment, serious liver damage may be progressing. This is not meant to frighten you. True acetaminophen toxicity from casual use is uncommon, but it is meant to help you take unexplained nausea or right-sided abdominal discomfort seriously, especially if you have taken more acetaminophen than usual in the preceding 24 to 48 hours. If you ever suspect you may have taken more acetaminophen than intended, do not wait for symptoms to get worse. Call your doctor or go to an emergency room. There is an antidote, N-acetylcysteine, that works very effectively but must be given early. Time matters. What patients who are on multiple medications need to know. Let me speak for a moment specifically to those of you managing multiple chronic conditions, which describes the majority of adults over 65 in this country. The average Medicare patient takes more than 5 prescription medications. Many take 8 or 10. When you are managing that complexity, the over-the-counter medications are easy to overlook in the conversation with your physician. They are not on the prescription list. They may not come up at appointments. You may not think to mention them. But your liver does not distinguish between prescription and over-the-counter. Your liver is processing every molecule that enters your body. The load is cumulative. If you have liver disease, any degree of it, non-alcoholic fatty liver disease is extremely common in adults over 60 and frequently undiagnosed. Acetaminophen demands extra caution. If you have been told your liver enzymes are elevated at any point, that is information your physician needs before recommending acetaminophen as your routine pain management option. If you have had hepatitis, alcoholic liver disease, or cirrhosis, acetaminophen safety should be a specific, explicit conversation with your hepatologist or gastroenterologist. None of this means you cannot take acetaminophen. For many people over 60, it remains the most appropriate choice for pain management. The goal here is not to create fear around a medication that, used correctly, does what it is supposed to do. The goal is informed use, conscious use, use that accounts for who you actually are at 65 or 70 or 80, not who you were at 35. The practical steps I want you to take. Here is what I am asking you to do based on everything I have just shared. Go through your medicine cabinet. Read every single label for any pain reliever, cold medicine, sleep aid, allergy product, or combination tablet you have. Write down which ones contain acetaminophen, APAP, or paracetamol. Add those up and think about what a typical day looks like for you. Bring that list to your next appointment. Tell your doctor and your pharmacist how much acetaminophen you actually take. Not the optimistic version, not the version you think sounds responsible, the real version, including the occasional NyQuil nights and the weeks when your back flares and you take it every day. If you are on Warfarin or any anticoagulant, make sure your prescribing physician knows your acetaminophen habits. Ask specifically whether your monitoring schedule should account for it. If you drink alcohol regularly, even moderately, tell your doctor that. Along with your acetaminophen use, let them help you think through whether your current habits are appropriate for your specific liver health. If you have any known liver condition, or if your liver enzymes have ever been flagged on a blood panel, make this a focused conversation rather than an assumption. And finally this, the assumption of safety because something is available without a prescription is one of the most common reasoning errors I see in medicine. Over-the-counter means the drug does not require a prescription to obtain. It does not mean the drug has no risks. It does not mean your biology is irrelevant. It does not mean your age does not change the picture. Acetaminophen has helped hundreds of millions of people manage pain safely. It continues to do that. The goal is to be the person who uses it well, not the person who found out too late that they were using it incorrectly. A word about the bigger picture. Everything I have described today fits inside a larger principle I talk about often on this channel. The premise that what worked for your body at 50 is still working the same way at 70 is one of the most persistent and dangerous assumptions in how we approach aging health. Your liver is different. Your kidneys are different. Your body's reserves, its capacity to absorb and correct and compensate are different. That is not a diagnosis. That is biology. It is normal. And it means that your relationship with even ordinary familiar medications needs to be reassessed as you age, not assumed. That reassessment is part of the work of living long and living well. It is not dramatic, it is practical. A conversation with your pharmacist, a question at your next appointment, a few minutes reading the labels on things you have been taking for years without looking closely. Those small adjustments made consciously are part of what I mean when I talk about longevity medicine. Not the spectacular interventions, the quiet ones that compound over time.